here to give us his inaugural lecture. Really, the point of this is to celebrate two things. One is the amazing science that he and his group do, and the second is to recognise the fact that he was made Professor of Epidemiology by the university in the last recognition of distinction exercise, which is fantastic for him, fantastic for us, and hopefully fantastic for his group as well, although it might have made him a bit more overbearing and obnoxious, of course. So it's a chance for us to celebrate Pete and his work. It's a chance for you to see a bit more about what goes on in the Institute. There'll be a lecture, it's being filmed. You'll be able to see it afterwards if you want. There will be a reception out there afterwards, and you're all, of course, incredibly welcome to join us for that. So I'm not going to do much in the way of introduction. Pete's no doubt going to tell us a bit about his own sort of pathway and how he's got to where he is. Suffice to say, I think we're in a big data institute here, by which I mean we like sort of large-scale, messy data sets that, when sort of combined with really cutting-edge algorithms, give us biological insight that can be used to transform lives. I think Pete's work truly ticks every last box within that, so his sort of perfect embodiment of what we want to achieve in this institute. And with that, I shall hand over.
Thank you very much, Gail. Thank you all for coming along this afternoon. So you're witnessing what is almost a once-in-a-lifetime event for me. I talk not of the inaugural lecture itself, but the wearing of a tie. I think the last time may have been my wedding, but I see this as an equivalently momentous occasion, so the tie has duly come out. Okay, so since this is an inaugural, I thought I would just say a few words about kind of my background and sort of the pathway that ultimately led for me to be here at the Big Data Institute. So one of the things I love about the BDI is the diversity of academic and disciplinary backgrounds that we have under one roof. And I suspect I'm contributing to that diversity by being a geographer. I'm not sure if there's others, maybe there are. Maybe they're keeping that quiet, if so. But I did my undergraduate and my master's in geography at Southampton. And from there, it was a sort of inevitably slightly circuitous route to end up in a Department of Medicine. So I shifted over within Southampton to a Department of Electronics and Computer Science to do my PhD. Then I moved to a Department of Zoology, which is where I stayed for 10 years until the fairly recent past. And then finally ended up in the Nuffield Department of Medicine and the Big Data Institute. So ostensibly, there's been kind of quite a lot of hopping between different disciplines. But actually, there's been a reasonably consistent theme, certainly from the onset of my PhD, which has been the study of the spatial epidemiology of malaria, with a primary focus on the most deadly form of malaria, which is Plasmodium falciparum. So there's the obligatory mugshot of that microorganism. Now, I've called this slide a tale of two pathogens because sort of as I reflected back a little bit in preparation for this lecture on the various kind of pivotal moments in this kind of career progression, I realised actually there was a different pathogen that played as big a role in determining where I finally ended up. And this is this chap called aphthovirus. Now, anyone who knows me or my work will be slightly surprised to hear of that. I don't think I've ever uttered anything about this virus before. I may not even be pronouncing it right. I've certainly never published anything on it. But back in 2001, I was preparing for my master's project in geography, and it was to be a traditional geography type project. So I was going to go out into the New Forest National Park, which is just adjacent to Southampton, wearing muddy boots and tramp around doing loads of field work, and it was to do with moorland ecology or something. Now at that time, this chap here, aphthovirus, was wreaking havoc across the UK in the form of the 2001 foot and mouth epidemic. So those of you who were in the UK at the time will remember this event rather well. The entire countryside was closed down for several months, and this happened just before I was about to embark on all this field work. So all these carefully laid plans to do this very traditional geography project were completely scuppered, and I had a matter of days to scrabble around and find a new project, or else my whole master's was going to kind of hang by a thread. So one of the profs, Pete Atkinson, who's now a dean at Lancaster, was offering a project in using satellite remote sensing and spatial statistics to investigate the spatial distribution of infectious diseases. Didn't really know much about that, but in the sort of spirit of beggars can't be choosers, and given my situation, I took that project. Found it absolutely fascinating, and kind of that twist of fate ultimately is what very directly led me off on the career path that ultimately got me here today. So that's kind of a little bit about my individual story, and it's actually all I'm going to say about myself as an individual. Throughout my career, I've been lucky to work in teams, so I haven't been carrying out science as an individual. I've been carrying out science as part of large collaborative teams. And the team that I collaborated with from the onset of my PhD, and that I then subsequently joined for my first postdoc 10 years ago, and which I now lead here in the Big Data Institute, is called the Malaria Atlas Project. So really it's the kind of combined formidable intellect of these smiling faces that you see in front of you, and their energy and their commitment that make MAP what it is today. So it's this that I hope to showcase today and hopefully do justice to. So to kind of, if I were to summarise what it is that MAP actually does in a single phrase, it would be global malaria surveillance. So to kind of tell the story of MAP, I need to intertwine that a little bit with the broader story of malaria surveillance itself, how that's kind of evolved over the past 15 years, how the questions and the priorities and the challenges have changed over that time period. And I'm going to do that by defining three distinct ages, three distinct phases, up to around about 2000, from 2000 to the present day, and then from here looking forwards as we as a global malaria community embrace the challenge of eliminating and ultimately eradicating the disease. So if we briefly wind the clock back to the era up to around about the turn of the millennium, from the perspective of malaria surveillance, we might legitimately label this the Dark Age, because global and national level kind of programmatic planning for malaria control was basically being done in the dark, in the sense that it was minimally evidence-based. Surveillance data such that they existed were incomplete, inaccurate, inconsistent. Any geospatial analysis that was being done on those data was ad hoc and informal. So just to kind of give you an idea of the kind of state of the art in global malaria risk mapping as it stood as late as 2004 from this example, and there's many other examples that I could have chosen. This is an attempt to describe the geographical variation in malaria risk globally in the early 2000s. And essentially you can just see some very broad categories of qualitative labels of different levels of risk. It's based on just a loose informal assembly of different scraps of data from different places. The way in which boundaries have been drawn between different categories of risk is just kind of mainly subjective. It's based on expert opinion. There's no attempt to do any kind of formal quantitative analysis, certainly no handling of uncertainty in the outputs. So you can see this doesn't really fit the bill as an input into robust global level planning for malaria control, whether at the national or sort of international level. Given that in only a few years after this map was made, the sort of global disbursement on malaria control globally was around about $3 to $4 billion a year. And this is the kind of level of evidence on which decisions about dispersing those funds were being based. So you can see it's sort of overtly unfit for purpose. So it was in this context that the Malaria Atlas project was conceived in the early 2000s and then ultimately launched around about 2005 by two then Oxford University professors, Bob Snow and Simon Hay, one of which I'm pleased to see is in the back row. Hi Simon, good to have you with us, now at University of Washington. So MAP was conceived basically to address this overt shortcoming in our ability to describe the global landscape of malaria risk. So its stated mission was to develop an open source cartographic information suite to inform malaria control and elimination globally. So if we now look back on the period since then from this vantage point in 2018, the period of time that's elapsed since the onset of MAP in relative terms can be considered the age of enlightenment for malaria surveillance. So we're now in a vastly different and vastly better situation than we were 15 to 18 years ago. There's been various catalysts for this. First and foremost, it's just been the recognition that if we want to adequately control a global disease, we need to adequately measure that disease and have an ability to understand what it looks like now and how it's responding to our control efforts. So this in turn led to huge investments by bodies such as the USAID, so essentially the US government, DFID, UNICEF and so on, in large programs of systematic data collection that included information on specific aspects of malaria. So this graph shows you the growth in the availability of data of one of our most important metrics, something we call PFPR, so Plasmodium falciparum parasite rate, which is essentially cross-sectional infection prevalence for P. falciparum, And a unit of 1 on that vertical axis represents a community where someone's, a study team have gone to that community and taken a random sample of individuals, tested them for the malaria parasite in their blood, and worked out the fraction that carry the parasite. So that's your infection prevalence. So you can see the kind of period. You may not be able to see given the size of the font, but sorry, I'll just get back. The y-axis goes to sort of 0, 1,000, 2,000, 3,000. This is time along the bottom. So the period up until around about the year 2000 was seeing averaging about 500 communities surveyed each year globally. And then a very sharp inflection point in 2000, and then over the subsequent decade, basically an order of magnitude increase, so that each year we're now getting around about 5,000 individual communities where we have an observation of malaria infection prevalence. This tail off in recent years is largely just explained by the lag time. It takes a certain amount of time for these surveys to get out in the field, the work to be done, the lab work to be done, the data to be published, the data to find their way to us and go into the database, which is why we see this tail off. But once those data are in, you'd expect to see basically a continuation of this much higher kind of status quo. So this is one of the things that MAP invests a lot of time and effort and resources in, is going out and collecting all of this data of any relevance to malaria that's out there globally. So our data estate includes information on the infection status of around about 5 million individuals, information on malaria control interventions, so did you sleep under a bed net, are you able to access anti-malarial drugs, for around 500,000 households. Routine case reports, so just measures of the number of malaria cases turning up at health facilities and then captured by the sort of routine activities of the health system. We have that type of data from around about 30,000 political and administrative units globally. We have around 50,000 surveys of observations of different Anopheles vectors, so the mosquitoes that transmit malaria, what species was recorded in what place at what time, and corresponding records of their insecticide resistant status. So to what extent are those populations susceptible to the main insecticides. Then we have a huge amount of data on environmental covariates. So this is data collected typically from remotely sensed imagery from satellites in space, recording measures related to temperature, rainfall, vegetation, the kind of things that dictate the intensity of malaria transmission that you're likely to see in a given place. And the sort of numbers get rather silly when you start talking about this type of data. So these are available generally at least at 1 kilometre resolution globally. Often the repeat cycles of these data is every 8 days. We have records going back 16 or more years. So just doing the basic arithmetic on that leads you to 3.6 trillion independent observations and growing kind of month by month as these data continue to stream in. So that's really the kind of big data part of what we do. Okay, so this massive expansion in malaria data and other related ancillary data has allowed us to, as a Malaria Atlas project, to address a whole range of rather important questions. And the question that we focused on for probably the first 5 years of the project was the most fundamental. What does the current global distribution of malaria risk actually look like? So over those 5 years, as I will explain in 3 or 4 bullet points, we developed methodologies. So we invested a lot of time developing these Bayesian geostatistical frameworks, which is essentially a formal way of taking point observations of a given quantity and turning that into a robust map. A lot of that basic theoretical statistics didn't exist or was computationally intractable when we began the project, and we actually contributed to that wider field itself in terms of the methodologies, and that's subsequently been picked up across a lot of other disciplines. We did all this work on data collection, so the parasite rate surveys, the routine surveillance, the case reporting data, the environmental covariates. So all these different ingredients fed into a kind of integrated framework, and the outcome of that are these 5 kilometre resolution global maps of malaria risk. So the metric that you probably can't quite read on these slides is parasite rate. So again, the fraction of children infected with malaria, blue is low, red is high, and you can see that we can map this out with that fine level of granularity across the globe. And these maps address some of those specific shortcomings that we identified in the earlier work. So they're based on formal quantitative methodologies that are replicable. Someone else could take our data, take our algorithms, generate the same maps and understand what we did and what the limitations are. They come with robust evaluations of uncertainty at the pixel level. So we're not coming out just with the image that you see on the screen, but with a whole load of iterative realizations from which you can construct posterior probability intervals of our prediction of parasite rate within each 5 kilometre pixel. So the first map that we generated was for the year 2007 for P. falciparum. We followed that up with an updated version for 2010. And that year also we generated the first map of P. vivax. So that's the kind of second most important malaria parasite. Okay, so having addressed this question of what does malaria landscape look like now in the present day, the next kind of logical question is to say, well, how has risk changed in recent years, given that we've, since the year 2000, had this huge global effort to drive the disease down? So to answer this question, we took our framework and we extended it from essentially a spatial analysis to a spatio-temporal one. So that involved lots of additional methodological development. It meant we had to go back to all our covariates and make sure we had those going backwards through time, both the climatological and environmental covariates, but also we had to develop a whole load of data around malaria control interventions. So we had to actually understand how the population coverage of bed nets and spraying and drugs had changed going back to the year 2000. And putting all these things together, we were able to reconstruct what we thought was the changing landscape of risk since the turn of the millennium. So this is work led by Sam Batt, Dan Weiss and Ewan Cameron in our group, published in Nature a few years ago. So this is the kind of thing we're able to generate. This is a map for the year 2000. Same metric as earlier, so parasite rate, infection prevalence in 2 to 10-year-olds. Grey areas are where there's minimal or no malaria. And then within the coloured region, the dark blue is very low malaria risk, all the way up to the yellows and reds, where you might have in 2000 upwards of sort of 70, 80% of children aged 2 to 10 carrying malaria parasites in their blood, so infected with the disease. And then as we flick through the subsequent years of the model output, 2005, go to 2010, and then through to 2015, you can see this transition from the reds and yellows through to the turquoises and the blues. So we've been able to describe for the first time this continent-wide decline in malaria. Then the obvious next question that everyone wants to know is, well, okay, so you've described that malaria has declined. To what extent can you attribute that to the global efforts and the malaria control interventions that have been rolled out across African populations, as opposed to other explanations like changing climate or changing, urbanization and other factors that are just happening in the background? So we were able to do this. To cut a long story short, we built models that related changing parasite rate to changing interventions, and so could robustly characterize the relationship between what happens when you change those intervention levels and the resulting response in terms of infection prevalence. And then we can run counterfactual analyses where we say, well, now we know what these relationships look like. What would the world have looked like if we didn't have any interventions, or they just remained at the levels they were back in the year 2000? And this is the kind of result we get from that. So again, it's a time series, 2000 to 2015. The same metric, parasite rate. So this is in a percentage scale, percentage of children infected on the y-axis. And then the red line shows the real world, the actual prediction for the decline in infection prevalence averaged out across endemic Africa over that time period. Now the black line is the counterfactual scenario. So that's what we predict would have happened in the absence of those malaria control interventions being scaled up. So just to explain the acronyms here, ITNs, insecticide-treated bed nets, artemisinin-based combination therapy, so that's the main first-line effective anti-malarial drug, and IRS is indoor residual spraying with insecticide. So you visit people's houses, spray their walls with insecticide, it knocks down the vector populations. So they're the three main tools that have been rolled out. And we're actually able to attribute specifically what fraction of the decline that we saw was attributable to those specific interventions. So you can see the green, that's the nets, the bed nets, takes up the largest wedge within that envelope. So they are the single control tool that had the biggest impact in bringing about those declines. Okay, so that kind of, in very short order, brings us up to the present day. We can now, from this point, look forward and start thinking about, well, how do we think the role of malaria surveillance and the kind of work we do is going to evolve, and what contribution will it make to this longer term agenda as we move towards the elimination of malaria? So I'm going to contend that a good way of characterising this phase that we're now beginning to enter is the space age for malaria surveillance, because spatially explicit surveillance data, spatially explicit analysis has proved its worth over the last 15 years, but I think as we move forward it will increasingly become seen as an essential component, as central to the process and the efforts towards malaria elimination. So to some extent, obviously I would say that, wouldn't I? That this is what I do. So what are my arguments for saying that this is going to become a central component of our efforts? One reason is that as malaria continues to decline, the spatial pattern of risk becomes increasingly heterogeneous. So spatial variation increases as the disease is driven down, and so knowing how much you have in different places becomes increasingly vital. The envelope of resources that we as a global community will be able to call upon to achieve malaria elimination is constrained now, and it will continue to be constrained into the future. There is not an unlimited amount of money to throw at this task. So when you put those two things together, very complicated heterogeneous patterns of malaria risk on one hand and very limited budgets for malaria control tools on the other, if we're going to achieve elimination, we have to enter this era of precision control. We have to get serious about being very sophisticated and very accurate and very robust in our ability to describe how much malaria there is in a specific place at a very granular level, so that we can get, cutting edge in our ability to stratify risk and to target exactly where we want to put specific interventions, rather than just kind of blanket approaches and one size fits all, which obviously neglect the fact that you've got very different patterns of underlying risk and are hugely wasteful of these limited and precious resources. So from our perspective, the kind of analytical questions around the spatial epidemiology of the system start to change as we go into this highly heterogeneous future for malaria. In particular, we need to go beyond simply being descriptive and saying this is how much malaria there is in this place, to strategic, by which I mean we need to be able to start informing questions like what exactly should be done, and crucially where should it be done on the landscape. So how are the kind of underlying data changing? How will they change in the future, and how will this contribute to this precision control era that we're hoping to enter? So one of the most important developments is that the most basic type of malaria data, so routine data, just people coming to a clinic being recorded as a malaria case, and that data being propagated up through a reporting system. That type of data is rapidly improving, and that even applies to resource constrained countries in sub-Saharan Africa. So increasingly that type of data are disaggregated. So rather than just getting a national level, we had 1 million cases last year, which isn't very much use to anybody. They're now often available at the level of the individual health facility. So at this facility at this particular month, we had this many cases. So much more rich, much more granular information about what's happening. Increasingly, vitally for us, they're georeferenced, so we know where that facility actually is. There's a latitude and longitude associated with it. Case confirmation is increasing, so rather than people presuming they have malaria when they go to a clinic, or clinicians assuming they do, and just presumptively diagnosing them on the basis of clinical symptoms, increasingly they're getting a rapid diagnostic test at the point of care, so we know that it's a malaria case, rather than just speculating. And then the digital systems themselves that are responsible for kind of assimilating those data and propagating them up through the system so that they're available to groups like us. Those digital systems, those digital platforms are increasingly in place and functional and working, so that the basic kind of curation of data is happening. There's also a growing diversity of ways in which malaria can be measured in the field, and this gets increasingly important again as you get down to low levels of transmission. So the traditional parasite rate surveys, where you randomly sample the population and look for parasites, they start to become not extremely helpful to us when you get down to infection prevalences of about 1 or 2%, simply because they become underpowered. So you need to sample huge numbers of people just to find any parasites at all. It's kind of a needle in a haystack problem. So increasingly we're looking to other metrics to give us insight about the variation in risk across the landscape. One technology is highly sensitive infection detection methods, including molecular diagnoses. So this is able to detect very, very low levels of parasites that are lingering in people's bloodstreams in a way that's much more sensitive than traditional point-of-care rapid diagnostic tests. There's a huge amount of innovation, as many of you here from Dominic and others groups will know, in malaria, molecular epidemiology, genetics, and some of the insights that's giving us into both parasite and vector population structures has enormous potential to inform this agenda. And increasingly serology, so the detection of serological markers in humans as a marker of past infections. This is an emerging technology that we're trying to get a hold on. And all the ancillary information, the satellite imagery, et cetera, is just exponentially increasing in amount and accuracy and precision. So our challenge essentially is to take all these emerging new data sources and to harness them, do the right kind of analyses on them to support these precision strategies that we're going to need if we're going to eradicate this disease. So what I want to do basically in the rest of the lecture is try and give a representative sample of some of the work that's going on in the group that I see as contributions from MAP to this wider agenda. So I'll briefly cover the following topics. Using case reporting, combining metrics, tracking coverage, looking at longer term trends in malaria, and then partnership and engagement. And I know most of the groups here, and I inevitably won't mention every little bit of work that's going on, so apologies in advance if there's anything that's not mentioned or given the highlight it deserves, of which there are many, but this is just meant to be a sort of representative example. So on case reporting, as I mentioned, these type of data are rapidly improving, and we have to make use of them. In many of these settings, there aren't parasite rate surveys, so this is basically all the information we have about the spatial distribution of the disease. So 2 examples, Haiti on the left and Vietnam on the right. Every dot there is a health facility, and either the size of the dot or the colour of the dot tells you something about the amount of malaria that's seen at that clinic in a given month or in a given year. So you want to use these data, but there's some fairly important challenges we have to overcome if we're going to integrate them in formal statistical mapping frameworks. So the first challenge is kind of a simple one in some ways, but the solution is complicated, and that is that we need to define a denominator population. So all we have is just an observation of a count. So at this clinic at this month, we saw 100 malaria cases. Now, alone, we can't interpret that as any indication of the underlying rate of disease. It's just an observation of count. And you see that immediately when you start comparing these counts. Often 2 facilities right next door to each other will have an order of magnitude difference in the number of malaria cases that they saw in a given month. Now, some of that variation is difference in actual disease rates. Most of that variation is due to just the different size of those facilities. One may be a big hospital drawing in lots of people. One might be a small rural clinic getting hardly any customers, as it were. And so you have very different amounts of people going to them. So how do we overcome this? A naive assumption, and one that actually is made quite frequently in this type of work, is to say, well, people will act rationally and they will go to their nearest health facility. So if you use that assumption, you can just draw what are called Tierson polygons or Voronoi tessellations around each of those points, encapsulating the area nearest to each clinic, and just say, well, the population that live within each polygon is therefore its catchment population. So you can go ahead and do that, and you can use those populations as denominators. You can standardize your counts and turn them into rates, and applying that to the Haiti data set, you get these standardized rates that look something like this. Now, you immediately looking at the map think, well, we've probably got problems here because there's no spatial structure to that, by which I mean the reds and the blues, the high and low rates, are just apparently randomly shuffled and mixed together. There's no clustering of high with low. It just looks like a kind of a speckled mess. And indeed, if you then take those data and try and run a kind of geostatistical mapping algorithm on them, you end up with something that looks like that. So it's very kind of patchy prediction of high and low risk in little sort of chaotic patches that doesn't bear much resemblance to what we actually know about the variation in the transmission of P. falciparum in Haiti. So that's not good enough. So we've invested a whole load of time, and this is work being led by Dan Weiss and Ewan Cameron, Katie Battle and others in the group, coming up with something a little bit more sophisticated and a little bit more realistic. So we've developed a catchment model that basically relaxes this assumption that people go to their nearest. It recognises that there's a lot of overlap in where people choose to go. And essentially we use kind of an adaptation of a gravity model. So kind of, I guess, imagining each one of these as a planetary body, and they have a certain draw to the population around them. And then we try to infer the weight, the gravitational pull of each of those health facilities in a sort of joint inferential framework along with the simultaneous prediction of risk. So we kind of iteratively shuffle around the weights until we end up with, subject to various constraints, with a solution based on various starting criteria. Now, when we apply this much more sophisticated model to the health facility locations, things start to look more promising. So we're seeing areas of high, like red areas, clustered together, areas of low, like the blue, clustered together as well. So more organisation to the patterns that we see. And indeed, when we go and map that, we get a much more coherent predicted risk map of incidence rate for Haiti. And this now does tally very nicely with what we think we know about the epidemiology on the island. So the most intense transmission is in this very poor peripheral region called the Grand Anse Peninsula, especially the coastal parts of that. We have a saline brackish water feeding Anopheles vector there, Anopheles albuminus, that likes this kind of these kind of brackish pools that you find in this coastal region. And then the other place of particular interest is somewhere called the Antibonite Valley. This is a marshy lowland valley that runs right the way into the inland area of Haiti, surrounded on both sides by steep mountainous areas which the mosquitoes don't like and where we have the darker blue. So the kind of point of this story, the punchline, is that if we want to use these new types of data, we have to be really quite sophisticated in how they're integrated within our frameworks. If we just use them in a naive way and sort of more basic geospatial modeling type approaches, we can get spectacularly wrong answers. And you can imagine if you're the National Malaria Control Programme of Haiti, who don't have as much money as they would like to spend on malaria control, and you're trying to distribute a limited number of bed nets and spray teams and so on, if you make those operational decisions based on this map, you're going to get things very badly wrong, and you're going to waste a lot of resources going to populations that maybe don't need them at the expense of those that do. So we like that approach. We think it's got a lot to offer. We're trying to scale that up across a much larger number of countries, and this is always the challenge with this type of thing. So we're developing kind of component parts. One thing we need to know is where all the health facilities are, and this is remarkably laborious to kind of compile this type of data. This is work we're doing in collaboration with an organisation called the Clinton Health Access Initiative. So this is all the health facilities we know of across 8 southern African countries. We need to combine that with information about the way people travel across the Earth's surface, so we can understand something about treatment-seeking behaviours and travel time and the effect of distance on your likelihood of seeking travel. And this has had a recent significant advance due to work by Dan Weiss in the team. He's just had a nice paper published in Nature, which is a global map of travel networks and accessibility to urban areas. So this feeds directly into this work on care seeking. And then we can build these kind of predictive surfaces which say, what fraction of people do we think would seek care for malaria given their location? Green areas where treatment seeking is high tend to be more urban, and you have more dense networks of transport connections and also health facilities. And then at the other end of the spectrum, these red areas, which are very remote, very far away from facilities, very poor transport links, and where it's very, very hard indeed to actually access care for malaria. So the second challenge is one of definition. And again, it's a kind of a simple concept, but a potentially complicated solution. So we have all this information about cases. This many cases appeared at this facility at this month. We need to be careful in how we interpret that type of data and what it actually means. So work done by Ursula, one of the DPhils, Ursula Damruppel, who's close to finishing a DPhil in the group, is starting to shed some light on this question. So first of all, she was able to just map out the prevalence of all-cause fever in children under 5. This is the 2-week period prevalence of children self-reporting or parents self-reporting a fever. Now, traditionally, up until about mid-2000, the WHO guidelines for malaria was anyone presenting at a clinic with a fever of any sort should be presumptively diagnosed as malaria. In the absence of a diagnostic test, there's a reasonable chance it is malaria. That was a reasonable clinical guideline. So under that paradigm, this population is the target population for malaria control. Then we had the invention of reliable rapid diagnostic tests for point of care. Increasingly, health facilities have access to these RDTs, and so the guidelines changed. Now, if you want to diagnose a malaria case in a clinic, you need a confirmed identification of a parasite in the blood using one of these RDT kits. So this map now shows the prevalence of people meeting that definition. So these are children who have a fever and a parasite in their peripheral blood. And that's a very different population. It's a much smaller population, which is potentially now the case definition for malaria. But there's a further problem, which is only kind of recently kind of becoming clear. We've been thinking about this for a long time, but it's only starting to percolate into kind of policy circles. So if you imagine you've got 60-70% of children infected with malaria at any one time, many of whom will be asymptomatically infected. On the other hand, you've got very diseased populations. You have very high prevalence of a whole range of pathogens that cause fevers in children. So when you put those two things together, there's obviously huge potential for a child to have an infection with malaria and a fever caused by something entirely different, and for those two things to be put together and to be called a malaria case. And that's what happens at clinics. Anyone who turns up with a fever, it could be a bacteremia, it could be a virus, it could be anything else, they will get an RDT, they may well have a malaria parasite in their blood, and that will be recorded as a malaria case, regardless of any kind of attribution of that fever to the underlying malaria infection. So Ursula has been able to, using cross-sectional household surveys, infer something about attributable fractions. So of those children with a fever and a parasite, how many are actually a clinical malaria case, rather than having something coincidental? And the map on the right shows the prevalence of that metric. Has a fever, has a parasite, and the fever is attributable to the malaria rather than being coincident. That's on the same colour scale as the middle map, and you can see that it's much, much further down the colour spectrum. In other words, there's far fewer children that meet that definition relative to the more broad one. So what does this mean in terms of what you're likely to see at clinics, and therefore how we should be interpreting data on cases from clinics? So this just summarises that kind of quite nicely. Each of these pies, which is a specific country, the entire pie is all people turning up at clinic with a fever and a parasite infection. And only the red part is the attributable fraction, and the green part is the coincident fraction. So our argument is that when we're enumerating cases from facilities, we should only be counting the red parts of these pies, and the green parts, while they still need treatment because they have an infection, they shouldn't be included in this envelope of clinical cases. So this is kind of great work from Ursula, really nice descriptive work, and there's an unambiguous result. The policy implications of this are being rolled out right now. I was in Geneva last week, the WHO, to kind of showcase this work, and it's an ongoing discussion, ongoing controversy, because it potentially fundamentally changes how we think about the total number of malaria cases that are extant in the world at any one time. Okay, so combining metrics. As I said, there's an increasingly wide array of different types of malariametric data. All of them are different ways of observing the same underlying process of transmission and pathogenesis and illness. What we'd ideally like to do is to be able to go to any given geography where we've been asked to stratify risk, and to basically opportunistically take whatever data happen to be available, whether they're from clinics, whether they're from surveys, whether there's people doing serology or molecular investigations and so on, and use them all to inform one coherent, integrated modelling framework. So we want to be able to standardise through time and across space. We want to be able to leverage the sort of unique benefits of some of these metrics over certain others. We also want to be able to infer important but hard to measure metrics from those that are more abundantly available. So just to give a couple of examples of some of the things we're working on here, a really simple one to start with is just developing a model that allows us to simultaneously within the same model use two different measures of infection prevalence. Prevalence as measured by rapid diagnostic tests on the x-axis, and as measured by the more traditional light microscopy approach, where you actually take a bit of blood, put it on a slide, and visually look for the presence of a malaria parasite. Two different ways of confirming if someone's infected with different sensitivities and specificities. But previously, they've all just been lumped together. Older data was microscopy, newer data was RDT, and the data were all thrown into the same model. That isn't really good enough because there's systematic differences. So this was quite an easy analysis. There's thousands of pairwise observations where the same individual has been tested with both methods. You can put all those data into just a simple empirical model, and it does a really nice job of defining a relationship between the two. And you can stratify that by things like the type of RDT kit you're using, whether the child's febrile, etc. Now, a more involved example is this one. So this is work led by Ewan Cameron, published in Nature Communications back in 2015. So we have the maps I've been showing have all been infection prevalence. That's the metric on the x-axis. That's a useful metric in its own right, but for many policy reasons, policy audiences, the metric we often have to present results in is the incidence of clinical malaria. So what's the rate of actual illness in a population caused by malaria? And that's the metric on the y-axis. We have about 40,000 observations of prevalence. We have about 30 studies that have actually measured clinical incidence in the community. So it's 3 orders of magnitude difference, essentially, in abundance of data between the x-axis and the y-axis. So to convert one to the other, we need some kind of reliable modelling framework to do that. So for this, we kind of took a leaf out of the kind of climate science playbook. We took 3 existing large, sophisticated mechanistic models that have been developed by other groups, one at Imperial, one at the Swiss Tropical Public Health Institute, and one at the Institute for Disease Modelling in Seattle, all of which were capable of taking prevalence and predicting incidence, stratified by age, by seasonality, by various other factors, levels of treatment, and so on. But they also had slightly different things, reflecting uncertainties in our basic understanding of the biology of that process. It's a complicated system because of acquired immunity. This is why this is a complicated relationship to understand, and it's poorly understood. So we put those 3 models together. We jointly fitted them to these 30 observational studies of clinical incidence, and we came up with this combined envelope predicting this relationship with a sort of envelope of uncertainty around it. And this has been the basis of our conversion from prevalence to incidence. One last example. So a new or emerging metric that I think will have increasing importance as we go forward towards elimination is serology. So this is where you're doing a cross-sectional survey, you're taking blood from people, but rather than looking for the presence of the parasite at that moment in the individual, you're looking at serological markers that tell you that that individual may have had an infection at some point in the past. And the particular type of marker that you look for gives you a different time window. Some of them are markers of recent infections, some of them are markers of much older infections in that individual. So there's a number of potential advantages of serology. I think there's a lot of kind of basic laboratory work that still needs to be ironed out until they're truly robust and standardized, but they offer some really exciting potential. So one is they're just more sensitive, because in a place with very, very low rates of infection, if you're not just looking for people who have parasites right now, but at any point in the past, there's just a higher frequency of people who will be seropositive versus parasite positive. So they're more useful in very low transmission settings. If you look at seroconversion by age, it also gives you an opportunity to infer something about changes in transmission in the past. So if there's distinct inflections that young people are not seropositive whereas old people are, or sometimes vice versa, you can use that within a mathematical model to infer differences in transmission backwards in time. So we've done a whole load of work to try and understand what these seroconversion rates look like, how they compare geographically to more standard metrics like parasite rate. And this map at the bottom just is one kind of proof of concept, which shows a map of this serologically based metric on the left and of parasite rate on the right. And we did some more formal work obviously, but just as a visual comparison, you can see that these two completely independent metrics are telling broadly the same story about the geographical distribution of transmission intensity in Cambodia. Okay, so tracking coverage of malaria control interventions. If we're going to inform countries in how they decide to deploy new interventions within their landscape, we need to know two things. We need to know, first of all, what's the underlying pattern of risk, but also what's the current pattern of intervention coverage. Now, it's kind of an obvious statement. It's surprising how poor information actually is on what's out there. What's the current landscape of people who are sleeping under nets? Where are the gaps? Where are people already covered and don't need any additional information? Any additional interventions? That type of information is actually harder often to get than basic data on levels of malaria risk. There's very good information on this type of thing from these cross-sectional household surveys, but they're temporally sparse. So when you have one, it's great, but you often have 3, 4, 5 years in a country where you have no survey. So in the intervening time period, you haven't necessarily got very much idea about what's going on in terms of their coverage status. So insecticide-treated nets, as I said, are probably the most important tool that we have at the moment. And we try to address this problem. We try to generate reliable estimates of changes through time at the national level in the coverage of those nets. This is work led by Sam Bart, previously here in Oxford and recently moved to Imperial. So he developed this temporal model that brings together 3 different types of information about insecticide-treated nets. These cross-sectional surveys where they're actually asking people in households, do you have a net? Did you sleep under a net? But then also information from manufacturers, people selling nets, how many nets went into a given country in a given year. And then thirdly, data from the malaria control programs themselves on their distribution patterns. How many nets at what time were distributed to what district? And using the kind of a stock and flow compartmental model, putting those 3 different data types together, Sam was able to come out with these very well-performing predicted time series of interventions. There's 4 different colours because there's 4 different ways of defining coverage. Do you own one? Did you sleep under one? Etc. But they all tell broadly the same story. So that kind of fills in the temporal domain. But we're also interested in the granularity, in the subnational variation in ITN coverage. So Sam extended the model from just the temporal time series to a fully spatiotemporal geostatistical model, going back to the georeference household survey locations where we know the level of coverage in individual communities and doing our kind of standard geostatistical algorithm application to develop these maps of subnational coverage of ITNs. And we can go beyond just saying, just the descriptive, just saying how many nets do people have in a certain place. We can start to use similar data and similar approaches to actually unpick some of the different reasons for suboptimal coverage and therefore inform different strategies for addressing those gaps. So in simple terms, there's 2 reasons why you don't sleep under a net. One is that you don't have a net, which is obviously fairly fundamental. So we say you don't have access to a net, your access is poor in that community. Another reason is that you have a net, but for whatever reason, choose not to use it. So that's a completely different reason for not, not being protected. And anecdotally, that second one is, if you believe the tales that you hear from lots of esteemed malariologists, is an important factor. So you hear these fantastic stories of, bed nets being used for fishing nets, football goals, bridal veils. I've heard about 15 different proposed uses for insecticide-treated nets that explain why people have a net but don't use it and don't sleep under it. So we actually wanted to do something formal and quantitative to investigate this and the kind of competing importance of these two reasons for not sleeping under a net. So the left-hand map shows rates of people who have access to a net, they own one. The middle map shows the second factor, it shows the rate of net use amongst people who own one. So that's the second issue. And then we kind of put these together into a combined metric which says, well, what would be the relative improvement in overall coverage if in a given place, if we completely solved the first problem, so made sure everyone had a net, but did nothing about levels of use, or conversely, gave a community no more nets at all, but assumed, enforced that everyone would use one in some way, using kind of behaviour change communication type techniques. And lo and behold, it turns out that when you put those two things together quantitatively, the map is overwhelmingly red, which means in almost every part of Africa, your problem is access, your problem is that the population doesn't have enough nets, the solution is you need to give them more nets. And only in a few very specific pockets was the role of non-use the predominant factor. And when you dig into these specific places, often that's due to seasonality and the fact that there's certain times of year when they legitimately aren't using their nets because there's not any mosquitoes flying around. So this kind of debunks some of these anecdotal but kind of quite influential ideas about how we improve access to nets. Okay, so this is very new work about kind of thinking over a multi-decade time frame into the future. So there's starting to be a consensus that there will be a kind of formal commitment to some kind of global malaria eradication campaign over a time frame of 30 to 40 years-ish. Now, whether there will be a specific date announced as part of that or whether it will be left vague, I'm not sure. I've heard it described that one of the drivers of the ideal time frame is the lifetime of Bill Gates. Bill Gates will obviously be a crucial player in any such endeavour, and he quite legitimately wants to try and achieve this massive milestone in his own lifetime. Obviously that introduces a certain uncertainty into the target date that we need to go for. Having met Bill Gates, very inspiring character, but I can confirm he was quite sprightly, and I suspect he's got excellent health insurance. So we could have quite a comfortable envelope in which to try and achieve this massive achievement globally. So if we're talking about 30 or 40 years, obviously the world is very rapidly changing under our feet in all sorts of ways for all sorts of reasons. Now some of those changes, and I'm talking about entirely separately from anything to do with malaria control, just the broad secular megatrends that are going on in the world and will continue to happen over that kind of time frame. So it's an important question for us is to say, well, what is the potential implications of some of these background trends in terms of the feasibility of malaria elimination, in terms of the sort of global level strategies that potentially need to be adopted if elimination is to be achieved. So to start this, and this is obviously a rather large topic with many, many dimensions that could easily take the rest of someone's career or 30 people's career. So to kind of get going on this, we've started to think a little bit about urbanization as one specific thing that we know is changing and that will potentially have a big implication on malaria. So this is just a sort of generic plot showing percentage of people in the world who are classed as urban. And as we all know, these trends are rapidly shooting upwards, mostly so, or most acutely, in those parts of the world that have the most malaria. So they're the places that are urbanizing most rapidly. We also know, and this is some sort of initial work that's going on in the group, Kate Tohig and Daniel Pfeffer and Jen Rosier, looking at just the relationship between urbanization and malaria transmission. So on the x-axis, we just have a kind of a metric, which is the percentage of a given region that is classed as urban, according to various spatial data. And on the y-axis, the parasite rate that we observe in a given location. And just from a basic, empirical representation of those data using dot plots, you can see a very striking relationship. As places become more urban, they have less malaria. Mosquitoes don't like cities, they like the countryside. Okay, so trying to sort of unpick that a little bit further, we're starting to think about, well, when we say urbanization, that actually encompasses all sorts of changes that are happening under that broad umbrella. One of these is that people are living in better housing. As you move from rural to urban areas, you tend to go from, in Africa, sort of traditional construction, mud, straw, that kind of building materials with very open housing, which is very permeable to mosquitoes, to more improved modern housing. It needn't be anything too fancy, but just having a concrete floor or a tin roof or screens on your windows, etc., makes a huge difference to the ingress of mosquitoes at night and your likelihood of being bitten. So Lucy Tusting, who's a Wellcome Fellow in the group, has done some really nice work on this. And in short, she's demonstrated that living in an improved house has a broadly equivalent protective effect to sleeping under an insecticide-treated bed net. Now, what we're also finding, this is work done by Lucy with Sam Bart again, is to try and enumerate the trends in improved housing. So what fraction of the population are living in what's classified as an improved house. And this is between 2000 and 2015. The red areas here are where we're seeing improvements of around about 25%, or 25% of the population now living in an improved house relative to the 2000 baseline. So reasonably consistent, steady improvements in East and West Africa. And obviously 10, 20, 30 years hence, perhaps very high fractions of the population will be living in what we now consider a modern house. That's obviously going to have huge implications for underlying malaria transmission. A couple of other factors that we're able to investigate and build up data sets on. So one of them is nighttime lights, the brightness of the Earth's surface at nighttime, which is obviously caused by man-made electrical lighting, primarily. This is a really good proxy that time and time again has been shown to correlate highly with things like poverty and economic development and so on. So it shows you where people are, where there's a density of population, but also the level of infrastructure of that population and how bright, therefore how bright that will be at night. So not a very good map because these places are always little pinpricks on the map, but again we're showing the change in nighttime light brightness over that 15-year period. And then equivalently for impervious surfaces. So again, this is one of the direct implications of urbanizing, is that the cities grow, you get a progressively larger fraction of the Earth's surface that is a rooftop or a road or a pavement or a car park or an airport. Again, somewhere where a mosquito, Anopheles, is not going to be seen dead. So as places urbanize and develop, you have these precipitous declines in malaria transmission. So this is another thing we've been able to develop layers of change through time. So what we've been able to do, just in this kind of pilot phase, is to put these kind of factors into our wider geostatistical model, where we also consider everything else that I've talked about, so changing intervention coverage, changing environmental background, temperature, rainfall, precipitation, and so on. Put it all in there and try and unpick the specific effects of these changing urbanization factors, looking retrospectively, going from 2000 to 2015. That then gives us a kind of empirical relationship between urbanization and malaria transmission. And we can then run these counterfactual analyses where we say, well, what if Africa was extremely urbanized? Let's fast forward 20 years and sort of artificially urbanize the continent, and then rerun our models and see what kind of reduction in infection prevalence that we might expect to see. And this is the kind of thing you get. So the top of these, so this is just countries in Africa, sort of in descending order of baseline parasite rate. The top of the line is infection prevalence in 2000. And then the bottom of the green section is where we are today in the real world. So that the size of the green bar is the size of the decline over the last 15 years. And then the blue section of each one of those is what we predict would happen under this highly urbanized scenario. So leaving malaria control interventions exactly as they are now, so not doing anything more in terms of malaria control, just this changing trend for urbanization in many countries will yield pretty substantial further declines without us as a malaria control community having to do anything at all. So when you start factoring in many other changes, maybe our job is not as daunting as it might seem here in 2018. Maybe a lot of things that are happening in the background will just inexorably lead towards a landscape that's more amenable to eradicate the disease. Or it could go the other way. So there's many other factors that we're not talking about here that might be antagonistic to our aims. So the whole point of this analysis will be to kind of expand this in a really kind of large-scale way. So more work on urbanization, but many other things as well. So changing demographic structure, obviously changing climate, changes in land use, which will include many things, including deforestation. And then layered on top of that, we can start thinking about what will be the impact of new malaria control tools as they emerge from the product development pipeline. So new drugs, vaccines, new classes of insecticide, more exotic things like genetically modified mosquitoes and so on. If we have this kind of background that adequately describes how the future will go, we have a more realistic framework in which to put those new tools in silico and try and understand their potential impact. And then this work is being commissioned by and will therefore feed into global policy. So it's being planned under the auspices of two different initiatives, the World Health Organization Strategic Advisory Group on Malaria Eradication, which the panel I sit on recently convened, that is essentially given the job of planning or putting forward, starting to initiate the process of coming up with a global plan for malaria eradication. And then in parallel to that, there's a new Lancet Commission that's just been announced, again on malaria eradication, that will showcase some of this work. Okay, finally, partnership and engagement. So the purpose of MAP ultimately is to inform malaria control policy. We learned very early on that we can't do that effectively if we don't build effective partnerships with a whole range of different organisations, if we don't engage, and if we don't communicate effectively both our results, but also in listening to people who have important questions for us to address. So I just want to talk about some of these most important partnerships, and prime among them is our collaboration with the Institute for Health Metrics and Evaluation in Seattle and their Global Burden of Disease study, which probably needs no introduction. You'll all, I'm sure, be aware of GBD, which is now an annual endeavour, published every year in the Lancet around about September time. So for the last several years, we've been working very, very closely with colleagues in Seattle, who by coincidence, many of them are here today. So hi guys, to provide all of our malaria estimates and feed those into this formal framework of the Global Burden of Disease study. So it allows this kind of very formal way of kind of comparing between different diseases and putting malaria in context along with all the other causes of morbidity and mortality globally. So the diagram on the left, this is in DALI, so disability adjusted life years, this combined morbidity and mortality metric on which GBD is based. And these are all the main causes that cause ill health and death. And you can see the malaria box there in its context, along with all the other sort of prominent causes. And then you can break that down. So here we're looking at deaths, we're looking at mortality only, just in sub-Saharan Africa, and we're looking at how they change through time. And malaria is this third slice down. So again, it gives us a framework for comparison between causes. The other crucial partnership is with the World Health Organization. I've said a little bit about that already, the Global Malaria Programme based in Geneva. We're a WHO collaborating centre in geospatial disease modelling, which means essentially we have a kind of a formal partnership agreement with the WHO, and our estimates can feed into their kind of official policy pronouncements and policy documents. So for 4 or 5 years now, we've been kind of key contributors to their annual World Malaria Report. So this is the official UN document that each year describes the current situation, global situation with malaria and trends and levels of impact. This is the document that's used by ministries of health, by national governments, by other UN agencies to inform that kind of formal governmental and intergovernmental level planning. So if you peruse the pages of the World Malaria Report, this is an example from 2017, it's replete with analysis from MAP. We're kind of key contributors to that, estimates of infection prevalence, clinical incidence, intervention coverage, and so on. And then finally, I must give a big shout out to our new website, map.ox.ac.uk. So numerous people within the group have spent the last couple of years working very, very hard, developing a kind of real fit-for-purpose front end for the Malaria Atlas project that gives people a way of interacting very nicely with what we do and a vehicle for us to disseminate our results. So if you go to that URL, you have all the kind of usual stuff you'd expect with a website, sort of background to the group and information about our projects and everything else. But you've also got some really nice interactive tools that allow people access to our data, to explore it, to download it and use it themselves as needed. So you can interactively select any of the many metrics that we produce maps on. You can pan and zoom and look at the particular place you're most interested in. You can overlay the data that we use to generate those surfaces, so you can interrogate those. You can pick out individual data points, get readoffs and everything else. So it's pretty cool. So I encourage everyone to have a little look if you have a spare 5 minutes. You can also go to individual countries and get information on time series and trends and so on. So I think I've whistled through that reasonably quickly, just about in time. Just a big thanks again to the team, to our many collaborators, to our funders, and finally, thank you to you all for coming along.